So without further ado, I'd like to introduce our keynote speaker and his co-speaker. We're very excited to have Dr. David Leader and his daughter, can you hear me? And his daughter, Allison Leader, here to talk with you about dental issues related to scleroderma. I'll give a quick background for Dr. Leader. So Dr. Leader graduated from Tufts University School of Medicine, Dental Medicine, and he earned a master's of public health from Tufts University School of Medicine. He also is very much engaged in the scleroderma community, serves on multiple advisory boards and medical advisory boards to support dental health and total health for scleroderma patients. In particular, he serves on boards like the Steffens Foundation, which was our keynote speaker last year, a representative who allowed us to learn a little bit more about patient or primary care education. So he works with that organization as well as with the National Scleroderma Foundation very closely to support our community and conduct research and to help spread education. Also, I always love it when I see somebody wins a teaching award. So you won a provost. Not only did you get the Doctor of the Year award from the National Scleroderma Foundation, but also a provost teaching award.
Thank you.
At Tufts University. So I am going to make sure you're in here, okay? Or did you pop yourself in? I will. I think you're good. I'll get you. I believe you should be able to advance your slides with this.
There we go. Oh, with this. Ooh, fancy.
Fancy, yeah. So this is a mic?
And I have the lavalier mic on.
So between the two. And also Allison Leader is Dr. Leader's daughter, who is a dental hygienist, also has an MPH. And she, as you guys know, our dental hygienists are key in protecting our teeth or getting us the right treatment or intervention before we lose our teeth. So thank you very much.
Thank you. Thank you for that great introduction. And thank you all for being here. And thank you, Dr. Silver, for inviting us. And let's see. So what I'm going to talk about today or what we're going to talk about is not only what you need to know about oral health and scleroderma, but what your dentists and your physicians should know. And let's get along on that. So our learning objectives are to know how scleroderma affects oral health, recommendations for home care, including prescription fluoride, recommendations for treatment of xerostomia or dry mouth, recommendations for microstomia, as your mouth gets smaller sometimes in scleroderma, recommendations for orthodontics, prosthodontics, periodontics, and oral surgery. And then we'll talk about how to find a dentist who is comfortable treating patients who have scleroderma. I do have a conflict of interest to report. I'm an advisor to a company that's developing a new line of oral healthcare products. I am not going to talk about these products at all. Let's see, and then a little information about me and Allison, but I think that we already covered that. And at the Scleroderma Foundation, on scleroderma.org, there is what I think is a good information brochure that you can find on the website and download. And I put the link on this slide. So if you have access to the slides, which everyone is welcome to, then you can find this information. It now, instead of printing as a multicolor brochure, it prints as an info sheet. So how does scleroderma affect oral health? Oh, this screen sharing bar is, let's see. There we go. All right. Okay. How scleroderma affects oral health? Xerostomia, about almost 3/4 of the people, more than 2/3 of people who have scleroderma have dry mouth, and that's a serious issue for maintaining oral health. Gastroesophageal reflux can cause a lot of damage to teeth. Physical disability, sclerodactyly, microstomia makes it hard for you to care for your own oral health, but also it makes it more difficult for people to care for your oral health. Resorption of tooth and bone, and we'll talk about that a bit. Of course, the psychological effects of having a chronic illness and the spiral of having depression and not being able to get through your activities of daily living, and then the oral health worsening because of that, and making you more depressed. And I did take out that section from this talk because of time constraints. Orthodontics, implantology, I'll mention that, and then, like I said, access, find a dentist. Let's see, there we go. All right, so let's talk about dry mouth. Dry mouth affects most people who have scleroderma, and also patients who have a lot of other autoimmune diseases such as systemic lupus erythematosus, of course, Sjogren's syndrome. It's part of the way that you know you have Sjogren's. Let me see, rheumatoid arthritis. Okay, so some of we like to think of the treatment of dry mouth on sort of a continuum. And we like to start with easy things that patients can do for themselves, like sucking on sugar-free hard candies. But a lot of people like to suck on acidic hard candies like lemon drops. You don't want to put more acid in your mouth if you have dry mouth, because you don't have the saliva to dilute the acid and to buffer the acid. So hopefully sugar-free hard candies that are not acidic. Increased water intake, that can help. Maybe just sipping on water. Artificial saliva, these are over-the-counter products that are not just water, but they have lubricants in them, and it helps moisturize your mouth and help maintain moisture. Some people who have issues with dry mouth might keep a bottle of Oasis or a Salivart on the dining room table, and when they're eating dinner, might give themselves a couple of sprays during the meal to help swallow food. Prescription fluoride, which Allison will talk about. Muscarinic agonists, these are medications that you can take that trick your salivary glands into making more saliva, or instruct them to make more saliva. Allison, would you like to talk about the fluoride interventions?
Yeah, so fluoride is a well-established, uninvasive way to help prevent that oral decay that becomes a lot more common with dry mouth. There's, of course, the individual methods, such as a child might be given fluoride supplements. There's the professionally applied methods, like the fluoride varnish that typically you would see done for your children at their very young pediatric appointments or through their teenage years at the dentist. That the fluoride varnish. And then there's prescription options such as the high fluoride toothpaste that I'll cover on another slide. And then there's the wider reaching public health options, which in the US, the most common is the fluoridated water. And depending on the country you come from, you might have experienced fluoridated milk, fluoridated salt. And it's just some high detailed information. Right, so this is the fluoride varnish, which again, as you can see, uninvasive. They dry your teeth off, paint it on. You're good for however long you go until your next cleaning. It's just a high concentrated dose, safe to have, dries right on your teeth. So different toothpaste options, MI paste and Prevident are both prescription toothpaste that you might want to ask your dentist or can you ask your physician about them as well?
Yes,
Yes, or your physician. The MI paste has non-fluoride vitamins in it that help remineralize your teeth. And the Prevident toothpaste has about 3 times as much fluoride in it as your over-the-counter toothpaste. If you do use that, I've realized with my own patients that a lot of people don't realize the way you should be using it is you brush your teeth with it, preferably at night before you go to bed, and then spit out just the excess of the toothpaste, and then wait at least a half an hour before you have any water, just so you can let that fluoride sit on your teeth, really sink in, do their thing. And then for your dry mouth, you want There's over-the-counter toothpaste options as well, such as Biotene. That the big difference is that it doesn't have this compound in it, sodium lauryl sulfate or SLS. That is very, very irritating to the tissues. In my own dry mouth patients, I've seen differences between appointments when I've had them switch between Crest toothpaste and an SLS-free toothpaste. So these are just some options for adapting a toothbrush to help with limited motion. But of course, the gold standard for an adaptive toothbrush would be an electric toothbrush, especially an Oral-B brush. That's what I use, or a Sonicare toothbrush. And these, the handle, it's large, easy to hold on to. You don't have to have the same range of motion. You just need to be able to hold it to your tooth surface and move it. And these are just a really great product. You don't need the one that's like hundreds of dollars. There's $30, $40 ones that are perfectly good under both of these brands. And just to highlight my favorite adaptive flosser, the one in the middle here, the Reach Access flosser, it's basically a toothbrush handle with a removable floss head on it. It's very easy to get into those small mouth openings. You can reach your back teeth really easily. People love these things.
Okay. I actually learned about the Reach Access flosser the second time I gave a lecture for the Scleroderma Foundation nationally. When I spoke about how important it was to floss, a lot of people were very upset because of the way the floss feels when it runs into the corners of your mouth. And then I said to the audience, well, do any of you have any recommendations? And one of the patients recommended the Reach Access flosser, which I had heard of, but hadn't considered using for people who have scleroderma. And it makes so much sense. And from then on, I've always had Reach Access flossers available to use for people who have scleroderma. So let's talk about dry mouth again for a minute. The medications there are medications that physicians and dentists may prescribe to improve your salivary flow. These are medications that affect the nerves that supply the salivary glands, and they basically trick the salivary glands into producing more saliva. They're called muscarinic agonists. There's two brands. One is Evosac, and this slide, and I think the next couple of slides are from that company. The main idea is when you have an autoimmune disease that's affecting your oral health, there is still some healthy tissue within the salivary glands. And if we can get that tissue, if we can turn it up, if we can supercharge it, then we can improve your condition. Now, the issue with using these medications, aside from the contraindications, which are listed here, is that it takes 12 weeks for the effect to be fully felt, for it to be fully potentiated. And you may not notice a change for about 6 weeks after you start using it. So you have to faithfully take this medication 3 times a day, whether you feel like it's working or not. After 6 weeks, you'll notice an improvement, and after 12 weeks, it'll reach the full improvement. The problems that I hear are from patients and from physicians and dentists working with their patients who say, oh, it's going too slow, why don't you double up on the dosage? And when you double up on the dosage, it increases side effects. And one of the major side effects is it can make you sweat more. So people who are taking double the dosage may find that they're producing a lot of sweat. Let's talk about gastroesophageal reflux disease. So this is a gentleman who does not have scleroderma, but he does have gastroesophageal reflux disease. And I'm going to use the pointer on the mouse for this. So what I saw the first time I met him and I looked in his mouth, I saw that his teeth were flattened. And he said, oh, well, they're flattened like that because I grind my teeth. And I said, well, sure, but that does not explain how you're missing enamel up near the gum line here where the teeth don't even touch, and on the sides of the back teeth where the teeth don't even touch. And it became very obvious that he was producing excess stomach acid into his mouth, and it was dissolving away the enamel. If you have a condition like this, you may have a dentist who thinks that you're drinking too much soda. In the case of patients who have silver fillings, what a dentist might notice is the fillings stick up from the tooth a little bit too much all the way around the filling because the enamel has eroded away, but the silver fillings don't. And this is why for people who have gastroesophageal reflux disease, I generally recommend using silver fillings over tooth-colored fillings because the metal ions help counteract the effect of the acid ions. And here's a case of a young woman who had gastroesophageal reflux disease. I'd placed all of those fillings the year before, took this x-ray a year later, and already she has a moderate-sized cavity here because she is still having problems with gastric reflux. And it is possible to tell the difference between gastric reflux and bulimia because gastric reflux and bulimia have a different pattern of enamel loss. So I always ask physicians to please treat gastroesophageal reflux disease aggressively. Dentists, we don't treat gastroesophageal reflux disease. We treat the effects of it. So this is something you need to speak with your physician. You may need a proton pump inhibitor or like Prilosec or a H2 antagonist like Tagamet, or I don't know what else they would prescribe because it's not my job. So if you have microstomia, there's a couple of exercises that you can do. Kate, am I still in the view if I stand here? Okay, great, thank you. Just on the edge, okay. Oh, my hand disappeared. So there's a couple of exercises that I recommend, and these are classic exercises. I saw these exercises in a paper that was published before 2005. So this is one of my former employees demonstrating how you would lubricate your lips, hook your thumbs across your wrists in front of you, hook your thumbs inside your lips, and then press up on one side and down on the other just to give your lips a stretch, and then reverse it. And you do this for about 10 or 15 minutes once a day. You can do this in the shower. The hot water has a positive effect. And you can do it while you're watching television. So this is a very effective way to increase your embouchure because when your mouth is small, you're being affected two ways. You're being affected by the tissue around your lips, and you're also being affected by what happens in your jaw joint. To help that, what I recommend is ask your dentist or your physician for a handful of tongue depressor blades. Assuming that your teeth are healthy enough for this, because some people, their teeth are very loose and they cannot do this. So you make a stack of tongue depressor blades that just fits in between your teeth and wrap a rubber band around it and then slide in one more. And that will give your opening a stretch. So once you get it to where you're having just a little stretch, you should not be feeling pain. It should not hurt, but just a little stretch, then leave it there for about 10 or 15 minutes. And this one, do not do in the shower, please. There's also these devices. I don't understand medical insurance at all. I'm a dentist. I barely understand dental insurance at this point. But I don't know if you know, but in Massachusetts, we had a new rule that dental insurance companies can only have a profit of 17%. So when you pay for your dental insurance in Massachusetts, the insurance company must pay out at least 83% of what you paid for treatment, and only for treatment, and not for advertising and not for donations. It's really amazing. And now we're trying to push to get that across the country. Anyway, Therabite and OraStretch are machines that do the same thing I just told you about with the lips and with the jaw opening. And and you need a prescription for the rental on the machines. I really don't know what that's about. And then you pay out of pocket for the replacement parts, like little pads that go on the teeth. I was wondering why this might be necessary for someone who has scleroderma, because you can you do the same thing so easily with your hands and with the tongue depressor blades. And then a woman was wheeled into my office, and she was very contracted with her legs and her arms like this, and she could not reach her face with her arms, with her hands. And her sister was doing her home care for her. And this seems to be a more clinical way of doing it if you have to do this for someone else. And so anyway, dentists and diagnosis of scleroderma. Oh, now this bar is covering the important part here.
If you move it to the side, does it go to the side?
Nope.
Oh, no.
Yeah, I'm special. Hide names of annotations. Nope, that didn't do it. Hide float.
Yeah.
There we go. Okay, and press escape to show. Okay, good. So this is a radiograph, a panoramic radiograph of one of my former patients who had scleroderma. An issue that comes up in dental exams when you have scleroderma is your teeth can seem loose. And your teeth seem loose because your teeth are not fused to bone. They're held into the bone by a ligament. So imagine a sock on your foot that is connected to the tooth and also connected to the bone, and it's thin. But in this case, you can see that it's become, thank you. You can see that it's become wider around all of the teeth. Now, the upper teeth are a different thing. The upper teeth lost all the bone around them, and that's also a sign of scleroderma. But dentists can pick up this widening of the periodontal ligament space on our x-rays. And this is nothing new. I have a citation here from the textbook that I used when I was in dental school in 1981. So this is a well-known feature of the disease, but your physician will never be able to pick this up because they don't have access to this type of imaging. So let's see, also there's an interesting paper that was published around 2014 that showed that the more of this widening of the periodontal ligament space you have, it coincides with having a worse progression of the disease. So the dentist can also help with the prognosis. Multiple tooth resorption. So not only resorbing bone, but also resorbing teeth. What I noticed early on working with people who have scleroderma is sometimes the teeth can just seem to start to dissolve away, almost like they're baby teeth, and they're losing the roots of the baby teeth. You know, when baby teeth fall out, there's no root. That's because the root has been resorbed. So this is Carol, who was a patient that I met in 2005. And she was sitting in the front row in my first talk for the National Scleroderma Foundation. She, and I have these radiographs because I referred her to a friend of mine to take care of her out in Western Mass. So you can see in the image from 2005 that the teeth are being eaten away from the inside out. And actually, it looks like they're being eaten away from the inside out, but I suspect that they're being attacked from the outside, not from the inside. Anyway, you go to the next image from 10 years later, and you can see how much more is missing. And the reason that she had this endodontic treatment is root canal specialists often think that if you have internal resorption of the tooth, if they do a root canal, the internal resorption will stop. The thing is, we really need to use 3D imaging, because in 3D imaging, we can see that this is not internal resorption, but external resorption that's only appearing like internal. This gentleman came to visit me in my office. He was around 60 years old, and he had just recently been diagnosed with scleroderma. And he said, I know you're the scleroderma guy, and could you just take a look at my teeth and tell me if my teeth are okay? And his teeth were great, except on this one spot on this canine, it's this tooth here. Actually, it's this one because it's reversed. He had this dark spot under the gum. And when you look at the photo above, you can just see the top edge of it where the gum is red and the tooth is a little white. The whiteness means that the calcium has been drawn out of the tooth. And I did a little surgery there, and I peeled the gum away from the root of the tooth. I scooped out the tissue that was eating away at the tooth. I put a little filling in. Next slide. Oh, here, I got the next slide. Oh, I forgot I made these bigger. I sent the tissue to Dr. Jonathan Garlick, who is a dentist and oral pathologist who does a lot of research in scleroderma at Tufts. And one of his PhD fellows took these images. So this is a not as much magnified, and you can see the whole piece of tissue. And now we're going to enlarge this much of it. And you can see that there's a lot of activity there. And in this one, can you point to the piece of dentin? There's even a tiny piece of dentin enveloped in this tissue, eaten away. And Dr. Garlick sent me this little message. When phagocytic macrophages fuse, they can result in giant cells that can resorb tooth surfaces and bone. So this is happening not just on the teeth, but also on the bone. And you see it in your fingertips, right? Fingertips. And you also see it in the bone around the teeth, like the image that I showed you of the x-ray. The gentleman had lost all the bone around the upper teeth. You can also see it in the angle of the mandible, which does not seem to harm anything. But in very rare cases, I've seen where it eroded away the entire condyle of the temporomandibular joint, the ball part of the joint that fits up against the skull and allows you to turn like this, and also eaten away the fossa, the part of the skull that fits into. These are very unusual cases. I only know of about a dozen of them in the country, and the treatment for it is surgical, but it can be treated. There are medications that you take that affect your oral health, and I have a list of them here, and you should all have access to these slides, and I recommend just if you have any of these issues, like let me see, gingival enlargement is a common one if you're taking a calcium channel blocker like nifedipine, or if you're having a lot of mouth sores in your mouth. You may want to talk with your physician about medications that you're taking that might be making it more likely for you to have these issues. And if you have a lot of mouth sores, like Allison said, you want to use the toothpaste that does not have sodium lauryl sulfate in it, because sodium lauryl sulfate, which is in most toothpaste that you buy over the counter, is very stingy when you get it on a mouth sore. And also, some people are sensitive to sodium lauryl sulfate and will get more mouth sores because of that. Orthodontics. Orthodontics can be very useful. As the skin tightens in your face, it kind of pulls the sides in, and it can make your teeth stick out forward a bit. We have a really descriptive name for that in orthodontics. It's called boating. And because, you know, the teeth sticking out in front and the smooth sides make it look like the prow of the boat. But it can be treated. And I've seen patients who have scleroderma have very successful treatments with this. You want to make sure that you're doing this with an orthodontist, not with a general dentist who has some training in orthodontics, which is fine for most people. But for people who have scleroderma, this is a higher level of a case, and you really need someone that has that extra training and experience. Also, if you're having resorption of the bone around the teeth, then this may not be a good idea. So it's important for the orthodontist to keep that in mind. Let's see, Invisalign is an option for people who have scleroderma. It does work a little more slowly than the wires and the brackets, but it's much more comfortable against your cheeks and your lips. Dental implants. Dental implants are useful for people who have scleroderma. Now, I don't have any scientific evidence about this. I only have experience. I do have some evidence that for most people who have scleroderma, implants work as well as for people who don't have scleroderma. From my experience, though, I would recommend that your surgeon who's placing the implants, whether it's a periodontist, an oral surgeon, or a general dentist, because a lot of general dentists are doing this procedure now, they probably should not be placing implants into areas where you have resorption foam, because then the implant won't, it's not going to make the bone stay. This is just a case that I worked on with an oral surgeon that I went to school with. He's a very fine oral surgeon south of Boston. And he had placed this implant. She had a single crown on the implant. The tooth next to the implant down the road years later started having a problem. We had to lose that tooth. So I made a new crown for the implant that had another porcelain tooth attached to it. We call that a cantilever bridge. So you have the abutment attached to the implant, and then you have the pontic, the false tooth attached to that, and that worked out very well for her. She took these pictures for me because I realized I forgot to take pictures, and she lived on the other side of the state. Pontic crown, okay. Access to care. From research that I've done with my students, we know that people who have scleroderma on average have to talk to 3 dentists before they find one who will take care of them. My father, the psychiatrist, has his opinions on why that might be, but let's not get into that right now. Dentists, for my master's thesis 10 years ago, I surveyed dentists to find out why it is that they're uncomfortable treating people who have scleroderma. Dentists do not get a lot of training in school for autoimmune diseases, except for the ones that are very common. And scleroderma, of course, is not very common. So what I found was that dentists who have more knowledge of scleroderma, who have more experience with scleroderma, are much more comfortable treating people who have scleroderma. My intervention for that is that we have to get dentists trained on it. But you can't get them trained in school, because in school, and one of my students surveyed American dental schools, we only have so many hours to teach students about autoimmune diseases. And there are over 100 autoimmune diseases. And like I said, scleroderma only affects a small number of people throughout the country, although every one of those people is very important. But if we teach more about scleroderma, then something else would have to go. So what I like to do is I like to talk with dentists. I like for patients to have information like the info sheet from the Scleroderma Foundation. And dentists are welcome to email me, and I can get them all the information that they need. I can talk with them on the phone. I can go over radiographs with them. Also, there are other people that I work with who can do that. A prosthodontist in Boston, a residency director in Chicago, and of course, Allison. So many dentists do have training to treat people who have autoimmunity. Oral medicine and public health dentists are specialists in that. General practice residencies are residencies at hospitals and at dental schools where they get extra training for this kind of care. And advanced education in general dentistry is another type of residency. There is an organization called Special Care in Dentistry Association, and their website is scdaonline.org, and they have a Find a Dentist button, and you can put in your location and they will help you find a dentist unless you live in South Florida, because South Florida doesn't seem to have anyone who can do this. I don't know why. dental schools, I like to kid Florida. Dental schools, and I grew up in Georgia, so I like to kid Florida. The dental schools often, like MUSC, have an oral medicine department. And so you can call the dental school here and speak to someone in the oral medicine department, they can fix you up. Tertiary care hospitals, large hospitals, often have dental clinics, and they are especially set up to help people who have chronic illness. And like I said, email me.